Now, anatomical pathology is, of course, about learning how to see. And nothing prepares you for this. I mean, many of us in our undergraduate years could not even focus a microscope. I definitely know. And my slides was like, okay, this must be kidney because I said the previous one was liver. Now, if you have the faintest idea, you know that liver and kidney is impossible to confuse. Anyway, that was my... but there's a rhythm to looking at a slide. And there's a movement through the magnifications that is a dance of its own. And it can be a fast movement. When you know what you're looking at and you go from the low magnification to the high magnification. Or it can be slow and iterative. And it's click, 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 go back, click, click. So the lenses dance. And once you have acquired this rhythm, you are on your way to becoming a pathologist. I couldn't resist. All of you know pathologists' obsession with visual heuristics. And Bleakley describes this as educated seeing, to allow vivid metaphor to inform or educate the naive senses. So now you see the nutmeg, and now you know why it's a nutmeg liver. I struggled a bit with a strawberry gallbladder, but use your imagination. But are you going to eat feta cheese again? Clinical reasoning in the visual domains. And this is not only anatomical pathology, but especially also radiology and dermatology, can therefore be regarded as an aesthetic issue, and as such has inherent ambiguity. And it is a dilemma for us, because we are expected to always make a final and definitive diagnosis. We're sending it to the pathologist will know. And this brings with it the danger that this tolerance for ambiguity may be lost. And Bleakley argues that the intrinsic ambiguity in pathology should not be regarded as an impediment, but as a resource. The imagination of the senses must be fostered, and we should be mindful of the limitations of our ambition to reduce this uncertainty. And there are 5 main factors that impact on the diagnostic abilities of expert medical practitioners in the visual fields. The one is habitual practice. How I see what I know. Saturated practice, when you see the same thing over and over and again, you develop fatigue. Restricted practice, where you don't maintain the balance between the technical aspects and this inherent ambiguity. Aesthetic practice, where you practice your eye by exploring other visual fields, such as the fine arts. And he calls it extending the eye. An ethical practice, humanizing the isolated matter. So remembering that there's a patient. So the next time you hear me say, oh, it is beautiful when I look at a slide, understand that I'm engaged in aesthetic practice. I am, of course, as my dad just said, fortunate enough to share my life with an artist who painted all of these. The dance performed at the post-mortem is the counterpoint of the operating theatre, where there's a lot of activity and a sense of urgency to preserve life. In the mortuary, we have the same infrastructure. There's the table with the person lying on it, the instruments, the green cloths, the pathologist and the prosector dressed in the scrubs, the face mask and everything. But there's that difference. But to me, performing a post-mortem is one of the most fulfilling activities as a pathologist. And to provide loved ones with closure and your colleagues with feedback surely has to be considered rewarding. And it's in the mortuary where I met Kwesi, the prosector, who always with a smile and always respectful, taught me just about everything I knew about performing a postmortem. A role model and a teacher of note. Now, the postmortem has many values, and the most important, I think, is that of the clinical audit. And in cases who come to postmortem, there is a diagnostic error of significance about 15 to 50%, depending on which literature you read. And these are mainly due to cognitive errors, not equipment failure and such. And the most common errors are premature closure or overconfidence. And the pathologist who performs the autopsy is especially vulnerable because if they apply these heuristics, it further complicates the issues around diagnostic error. And so I became a pathologist and I was appointed in anatomical pathology. And Professor Neil Rousseau, who was our HOD, died about 2 years later. And I literally inherited respiratory pathology, which gave birth to my PhD 5 years later. And a few months later, I also became a widow when my late husband succumbed to his pethidine addiction and left me destitute. But in 1999, I met my life partner, Hester de Vos, and we've been together ever since. And we are a good match, because she keeps me grounded when I float off too far in the clouds. And as I said, she's an artist. So I get the opportunity to foster the imagination of my senses at home. And of course, we both love dancing. In 2002, I received the Rector's Award for Teaching Excellence, and I used it to go to the Association of Medical Educationists in Europe in 2004. It's a conference, and this was a true turning point in my career. I always loved pathology, but I loved teaching pathology way more, and I still do. And what gives me the most satisfaction is the moment when a student realizes that he or she has the ability to come to a diagnosis by applying clinical reasoning. That aha. So now I'm going to spend some time on this slide. How does clinical reasoning work? Briefly, when we reason, there's a system 1 and a system 2. And system 1, and you don't have to look at that slide, it's just to confuse you. System 1 is an intuitive process. When we've seen it before, we look at it and yes, we know immediately what it is. System 2 is analytical. It's slow. It takes energy. We have to engage in it consciously. And that's when we are faced with a difficult problem or something we haven't seen before. And we need to learn the balance between the two. And as you become an expert, you live more and more in the system 1 world where it's intuitive. But you always have to be aware of the fact that maybe I must stop for a moment and reflect and make those little lists and see if my diagnosis is correct. Now this is a model developed by Charlin, and this is the first level of 17. Focusing on clinical reasoning. And when I saw this model the first time, I had an acute attack of jealousy because it is so beautiful, so elegant, and so complex. But even in its 17 levels, it's only the tip of the iceberg. And in 2005, I became a FAIMER fellow and I returned a changed person. I learned so much about education and leadership, and I got to dance with the big guns in medical education. And this experience expanded my horizons in ways I never expected. And amongst other things, I learned about communities of practice and the concept of communities as learning as a cognitive apprenticeship in communities of practice. All the learning. So, the concept of communities of practice is at the heart of the next few steps that I want to share with you in relation to SAFRI. And this is the fellowship that we started in 2008 based on a similar model to FAIMER and also funded by FAIMER. And this approach that we use is aligned with the argument that we learn best by being immersed in the messiness and the complexities of activities, projects, and practices. And in this fellowship, it is focused around an innovation intervention in education that they do at their home institutions. And everything that they learn in the fellowship is focused on equipping them to successfully implement that project. And to date, we've reached 77 fellows from 15 countries and 7 professions in Africa. This messiness is also reflected by Engstrom, who took learning from communities of practice to the cultural historical activities theory, or for short, CHAT. And in CHAT, learning occurs through time and through space. And there are complex interactions and relationships between people and artifacts. And this results in the development of a professional identity.